Good day, everyone. I'm Dr. Sandy Haraba, and today I will discuss to you the summary of the National Rabies Prevention and Control Program and focusing the roles and responsibilities of the animal bite treatment centers. So this is in accordance to the Republic Act 9482. Before anything else, I hope you finish taking the pretest exam before you proceed to my lecture video. So today I will share to you my slides. All right. March is Rabies Awareness Month with the slogan of End Rabies Now Na. Once again, I'm Dr. Josephine Santi D. Haraba. So you are here in the Philippines. Figure 1 shows the above map of countries affected with rabies infection. So the Philippines falls to the category of high risk, as you can see. So together with the international community, they have developed and formulated the 5 pillars of rabies in elimination. The stop are namely socio-cultural, technical, organizational, political, resources approaches. And here in the Philippines, we have noted that at least one-third of these deaths occur in children aged 15 years old and below. Conversely, the confirmed number of positive human rabies in cases increased by 13.5%. And affected regions have the highest number, regions 3, 4A, 5, and 12. That's from the census from 2008 to 2018. And most of the rabies cases comes from the canine species with a total of 96%. Rabies and its transmission. The only documented human-to-human cases were through transplants like cornea, liver, kidney, and other organ transplants. Bites from infected animals are also common. However, bites from rabbits, other rodents, reptiles, and birds do not pose a risk for rabies infection. So do not forget that. The incubation period lasts for 1 to 3 months. However, 90 to 95% of these cases is less than 1 year, but may be longer in 5 to 10% cases. The pathogenesis comes from the virus multiplies in the muscle cells, myocytes that may invade the nerve directly without prior multiplication inside the myocytes. So just a gist, so rabies virus attacks or targets the nicotinic acetylcholine receptors of the axons of your peripheral nerves. So they enter via peripheral nerves, then to your spinal cord, then to your brain that can cause encephalitis. And the commonly affected areas are hippocampus, limbic, medulla, and cerebellum. Once the virus reaches the CNS, it occurs the replication inside your neurons, viral budding through virus spreads and affects the nearby or the adjacent brain cells. Then disseminate occurs to the peripheral tissues, to the muscle fibers, salivary glands, corneas, adrenal medullae, lacrimal glands, myocardium, and so on and so forth. So we have these stages, the clinical stages. First, the prodromal, wherein it lasts 0 to 10 days with non-specific manifestations. It is the initial viral replication inside your muscle cells before it enters the brain. That's your prodromal. Then we go to acute neurologic symptoms, which may last 2 to 7 days, characterized by hyperactivity, hypersalivation, disorientation with CNS manifestations. And mostly, it exclusively within the gray matter during the replication. The stage is two types. We have encephalitic or diffuse type, which occurs 80% of the cases, and paralytic or dumb type, which is seen on the 20 cases. So to differentiate, please look at the table. So we have the neurologic. Mostly it's the main symptom is spasm of the pharyngeal muscles, often triggered by an attempt to drink water or hydrophobia or by blowing air on patient's face, aerophobia. For the dumb type or paralytic, there is a complete paraplegia that eventually develops with paralysis of the respiratory and pharyngeal muscles. So it can be symmetrical or asymmetrical with flaccid paralysis, but the order is usually ascending, so ascending type. Other than that, coma begins with 4 to 10 days after the symptoms started, and cardiac arrhythmias, hyperventilation, hematemesis, and pituitary dysfunction. Next is death. 73% die within 3 days of onset, while 84% die within 24 hours of admission. For our differential diagnosis, the top two, we have GBS and encephalitis. So for GBS, like your paralytic or dumb type, so affects more nerves outside the brain and spinal cord. It's also a rapid onset, and the symptoms developed in ascending order. Next is encephalitis with CNS and symptoms, of course. A deep loss, coma may occur and may last for days to weeks. So, how to diagnose? We have the intravitum diagnosis of human rabies. Then we can get the samples through the saliva, urine, skin biopsy, serum, and CFS, or the cerebrospinal fluid. Then we have the recommendation from WHO, from other research also through brain biopsy, skin biopsy. So what does the Department of Health do to prevent and also to implement RA 9482? So the vision and goal is to have rabies-free Philippines by 2030. The goal is to end human deaths from dog-mediated rabies by 2027. So it is a multidisciplinary approach that strengthens the linkages with program managers, public health workers, veterinarians, local chief executives, and other stakeholders, including the general public, to achieve rabies elimination. So the components follows mass dog vaccination, the post-exposure prophylaxis and pre-exposure prophylaxis, the health promotion. So do not forget EO84 that March is Rabies Awareness Month, and it is a nationwide program in collaboration with the LGUs, national, regional, local offices of the Department of Health, and other partner agencies. And September 28 has been declared as World Rabies Day. This is through a mass communication campaign. So the management and implementation structure of the National Rabies Prevention and Control Program, this is known as Anti-Rabies Act of 2007. It is headed by the Department of Agriculture, the Bureau of Animal Industry, and implemented by a multi-agency and multi-sectoral agencies. This is through your national level, vice chair by the Department of Health, members with the ALG, DepEd, and other partner agencies of the local government. This is the regional structure. This is the provincial structure, the city, and the municipal. Of course, here in Northern Mindanao Medical Center, we are partnered with the City Health Office of Cagayan de Oro. And this is our barangay organizational structure. So these are the roles of the Department of Health. So let's focus ourselves to the roles and responsibilities of the Animal Bite and Treatment Center. It must receive allocated immunizing agents from the department, regional office, provincial rabies coordinator, ensure the proper cold chain management, screen all animal bite cases and manage accordingly, maintain animal bite registry, and it must be updated, submit the accurate report to the Department of Health on quarterly basis. So that is quarterly. Advocate to the local chief executive for additional funds of the program, conduct investigation, and conduct health promotion activities. So here in Northern Mindanao, this is our Animal Bite Treatment Center, and this is our certificate of quality service. So issued on November 11 this last year and valid until November 11 in 2022, signed by the Regional Director of the Department of Health. So the task of the ABTC personnel, again, receive the immunizing agents, ensure the proper cold chain management, screen, maintain the bite registry, accurate report, advocate for additional funds, investigation of human rabies cases, and do health promotion activities. So under our Animal Bite Treatment Center, we have a group of public health specialists, family medicine specialists. So, and they must have their training done, certified for animal bite treatment health personnel. So as I've said earlier, they must undergo training by the Department of Health. They have their own vaccine, maintain the registry, report quarterly, do the investigation, and health promotion activities. Do not forget the roles and responsibilities. It is for this reason that an integrated approach to its detection and management can be described by 4 areas. These are the 4 R's, namely recognition by rabies risk assessment and the clinical signs of rabies in domestic animals. Number 2 is recording. 3 is reporting, and 4 is referral. Recognition, recording, reporting, and referral. So we go back to the possibility of rabies virus transmission capable of shedding, transmitting virus. That's for all mammals. That's all mammals. Only mammals pose a potential risk for rabies transmission, and virus cannot be transmitted through bites and scratches or other contacts, such as birds, reptiles, amphibians, fish, or invertebrates, and most rodents. So this is a review of the pathophysiology of the rabies infection, as I've said earlier. So how do we document puncture wound? We must state if it's 2-point or 1-point punctured wound, if it's with contusion or without contusion. We will also note for any signs of lacerations, abrasions, and etc. So these are the factors that we must also document: animal species, number of bite location, bite severity, medical attention. Is it bite provoked? Animal's health, rabies vaccination, animal available for quarantine, rabies recently detected in the region, victims' anxiety about rabies. So recognize the clinical signs of rabies in domestic animals, and these are the following. Please note and document. So PPE to be worn during the removal of the animal's head. Of course, we must wear face shields, surgical gloves, rubber gloves, heavy duty, and plastic aprons. The test procedures for detection of rabies is the direct fluorescent antibody test. It's very rapid and a reliable test. And the animal should be reported to the local health officer within 24 hours. Rabies tests are reported during DOH animal rabies case report form. For the disposal of the animal carcasses, it must be placed in red biohazard bag and carefully labeled with words biohazardous waste. So again, recognize the earliest period prior to onset of clinical signs prior to death in which rabies virus is present in the saliva of some mammals. So what you can see is just the days prior to onset and the days prior to death. That is why we must take into account the status of the mammal or the biting animal. We must monitor it within 14 days. So this is the research base. Next is recording. Record information in a manner that is accurate, complete, consistent, and legible. So how do we record? And remember the 9 points of information. The noi, poi, doi, toi, soy. Exo, extent of bite wounds. COA, condition of animal. ERV, anti-rabies vaccination history for biting animal and bitten person. Pro, is it are there provocations or triggering events? And COB, category of the bite. Reporting must be within 24 hours because all animal bite cases are category 1 of our PIDSAR. For the RHUs, they must report to the higher facility. And of course, the higher facility is the NMMC, which is the tertiary hospital of the region. That's the referral system. History taking, as I've said earlier, please take note for any signs of encephalitic symptoms and paralytic symptoms. Document them. So we do our physical examination, including the neurologic. So your neurologic physical examination must be complete. For the diagnosis, we do the saliva collection or the antemortem. Minimum 3 collections and 4 hours apart is required. So we have the voluntary and next is aspiration of the research staff. We have the postmortem collection, the CSF. So we get it through atlanto-occipital joint. And these are the recommended packing and handling of specimens for transport. And our research facility for that is our RITM, Research Institute of Tropical Medicine. So how do we treat? We can give diazepam, midazolam, benzodiazepines, haloperidol, and diphenhydramine. And these are the dosages for pediatric and adult preparations. Please take note for any hypotension and dystonic reactions, especially for haloperidol and diphenhydramine that may cause sedation, especially if other sedating agents are also given. So please monitor for hypotension. We also give supportive care, communication to the family, and give them the prognosis. So we isolate patients in the isolation room. You can see here in San Lazaro Hospital where rabies patients are taken during advanced stage of infection. So when to refer to higher facility when diagnosis is not certain, and pregnant rabies patients for cesarean section. So we must include this in our referral forms where, what type of animal, why, who is the animal's owner. So everything must be complete. Infection control, especially for health workers, they must wear proper personal protective equipment, and they must receive pre-exposure prophylaxis and rabies vaccine boosters. Rabies in pregnancy, there is no contraindications for anti-rabies vaccination in pregnant women. They must be managed the same way as non-pregnant. And of course, if the rabid mother is in 3rd trimester and the baby is viable, emergency CS is recommended. So how do we dispose of the dead bodies? In accordance to the PD 856, the Philippine Sanitation Code, Section 91 states that they must be buried within 12 hours, just like our COVID-infected patients. Medical management of the animal bites. The key steps are wash the wound with soap and water, liberal irrigation, debridement, and if signs of infection are present, we must start antibiotic therapy and do swab culture. But of course, we do swab culture before antibiotic treatment. So what organisms are most likely present? The Pasteurella, Streptococcus, Staphylococcus, or the anaerobes. I call this SAPs: Streptococcus, anaerobes, Pasteurella, and Staphylococcus. So this table shows categories of rabies exposure with corresponding management. So we must remember, I know that you are very familiar with this, but a gist of the information is that we must remember that category 1, skin barrier is intact and no vaccine or RIG is needed. Exposure prophylaxis may be considered for high risk persons, especially for health workers or those who are working uh, in animal quarantine or in the veterinary clinics. Next is category 2. There may be loss of skin barrier with or open or closed wounds, with or without bleeding, or those including induced to bleed. Complete vaccination regimen until day 7, regardless of the status of the biting animal, and RIG is not indicated. Next is category 3. No. Category 3, this includes the areas of your head and neck area. Of course, everything that transpired regardless of the area, with respect to the areas of the head and neck, they must be put in category 1 or in category 2. But when the location is already affecting your head and neck areas, immediate, it's under category 3. So start the vaccine and RIG immediately and complete the vaccination regimen until day 7, regardless of the status of the biting animal. All right? Don't forget that. So these are the management of patients with category 2 and category 3 exposure where biting animal cannot be observed or dies within 14 days of observation. So there are certain conditions where IM injection is indicated and where ID injection is indicated. We must remember these special populations. Okay, number 1 are patients with chronic liver disease. Those are taking chloroquine. Those are taking systemic steroids. Those who are immunocompromised shall be given with vaccine using the standard IM regimen and RIG for both category 2 and category 3 exposures. The only special precautions that we give where IM injection is contraindicated shall be to the patients with hematologic conditions. They must be given through intradermal route. Okay, remember that for both category 2 and both category 3 exposures. Okay. However, if the biting animal has remained healthy and alive with no signs of rabies until 14 days after the bite, no treatment is needed. Doc, do we give antibiotics? No. Doc, do we give vaccines and RIG? No. No treatment is needed. Bites by rodents, guinea pigs, rabbits shall not require rabies post-exposure prophylaxis. Remember that. Again, post-exposure prophylaxis is previously immunized animal bite patients. Just do local wound treatment and give the necessary vaccine. So these are the schedule. Again, if the patient receive complete PrEP day 0 to 7, or patient receive at least day 0 or 3 doses of PEP via ID or IM, do we give RIG? No. The management is just categorize if it's a high or low risk bite, but do not give RIG. Doc, do we give RIG for patients who are immunocompromised or bitten by a bat? Yes, give full course of the PAP. If the patient either did not complete the PrEP or PEP, then yes, give the RIG. Give the full course of PEP. Now, this is how we categorize the level of exposure, if it's high risk or low risk. And these are the criteria. So for GIDA, especially for GIDA barangays, we give immediately the booster injections to the patient. And for the low risk, just observe the biting animal for 14 days. So for category 1, PEP is not indicated. For category 2, these are the following recommendations. Dog cat shall be at least shall be at least 1 year, 6 months old, and has updated vaccination. So we must take note if the anti-rabies vaccine for the biting animal has been given for the past 2 years. So if the biting animal starts to show sign of rabies, immediately give vaccine and RIG. And do not forget, if the biting animal remains healthy within 14 days, there is no need to administer anti-rabies vaccine. I mean, the CCEV back against rabies. For category 3, these are the following recommendations. Everything must be given, regardless. But again, the PEP shall not be required for the bite of the following biting animals: for rats, rodents, snails, and other reptiles, or fish. We give active immunization. We give active immunization for the rationale of the T cell production in order to neutralize the rabies virus in the body. So, how about if the patient comes to you, more than 1 week from the date of incident or from the date of biting incident? So, do we give rabies immunoglobulin? The answer is No, we do not give. After 7 days, the body develops a natural antibody, and the patient's body is capable. So we do not recommend giving RIG after 7 days. So these are the list of the TCV provided by the NRP-CP to animal bite treatment centers with corresponding preparations and dose. Our PVRV, purified virucil rabies, preparation of 0.5 ml per vial or 1 ml per vial. And this can be given via intradermal and intramuscular. The purified chick embryo cell vaccine or PCECV, the preparation is 1 ml per vial. So here in NMMC, what is available is our Vaxirub. It is a PCECV, Vaxirub, and we can give it 0.1 ID and 1 ml IM. So for the passive immunization or rabies immunoglobulins or RIG, the half-life is 21 days. That's approximate half-life. And there are types in which the available here in NMMC is the Ikirab. Ikirab is a type of equine rabies immunoglobulin. And the dose for Ikirab is 40 IU per kilogram. But of course, if human rabies immunoglobulin is available, the MKD dose is 20 IU per kilogram. So how do we compute? Use this computation formula as follows. The gauge of the needle must be 23 or 24, and 1 inch length must be used for infiltration. Multiple needles injection into the same wound shall be avoided. To the management of the adverse reaction, we give adrenaline or epinephrine, and these are the MKD dose for adults and children. We give also steroids after epinephrine. For hypersensitivity reactions, we give oral antihistamines, either single or in combination. Status quo for 24 hours, despite a combination of antihistamines, may give short course 5 to 7 days, combined with steroids. This is our local wound treatment. All right, we must take note of this. Suturing of wounds shall be avoided at all times. Why? Because it may inoculate virus deeper into the wounds. Wounds may be capitated using sterile adhesive strips. If suturing is unavoidable because it's very bloody, there's profuse bleeding, it shall be delayed for at least 2 hours after administration of our RIG to allow diffusion of the antibody to occur through the tissues. Anyway, suturing can be done within the first 24 hours. Any ointment, cream, or wound dressing shall not be applied to the bite site because it will favor the growth of bacteria and will occlude drainage of the wound, if any. So again, suture must be suturing must be avoided, but if it is unavoidable, please delay it and give RIG first before you suture the wound, at least 2 hours. Next is guide the tetanus prophylaxis in routine wound management. So if the vaccination history of the patient has unknown or less than 3 doses, we give TD and ATS. And if the patient has received 3 or more doses, we do not give TD or ATS. TDAP may be substituted for TD if the person has not received TDAP and is 10 years or older. DPT may be given for patients 7 years old and below, and TT may be given if TD is not available. Yes, if more than 5 years since the last dose. So these are the considerations when we give our tetanus toxoid vaccine. In our barangay health centers, the most readily available form of vaccine is TD. TD is readily available. Next is the recommended antimicrobials for infected wounds. We can give coamoxiclav, fluoxacillin, and ceftriaxone. So these are the MKD dose. Please take note. For penicillin allergic patients, we give doxycycline for adults and erythromycin for children. For instances, there are no obvious signs of infection. Doc, the wound is clean, it's not contaminated or dirty. We can give amoxicillin as a prophylaxis. 500 milligrams POTID for adults, and for children, amoxicillin 30 to 45 MKD in 3 divided doses. Please take note that educate your patients that tandok, batu, rubbing garlic on the wounds, and other non-traditional practices may further contaminate the wound and shall be avoided. The vaccination general principle is that it must be stored within the 2 to 8 degree Celsius in the refrigerator and not freezer, so it's inside the body. Once reconstituted, vaccine shall be kept in the refrigerator and used within 8 hours. Injections shall be given on the deltoid area or arms in adults and anterolateral aspect of the thigh in infants. And we must avoid gluteal area as absorption is unpredictable. So these are the treatment regimen schedule. What we use is the 2-site intradermal schedule, the 2220. But of course, For WHO pre-qualified vaccines, the day 28 dose may be omitted, and we can give the following 22200, and it is sufficient. For the Institute Pasteur de Cambodge PC intradermal regimen, it's 22200 to give on day 0, day 3, and day 7. And if the vaccine dose is delayed for any reason, the PEP shall be continued and not restarted. Other routes are for Zagreb regimen schedule, the 20101 IM. This is for IM. So we give it to day 0, day 7, and day 21. For the shortened intramuscular schedule, we give it the day 0, day 3, day 7, and day 14. So please take note of the following schedules. So how do we minimize public health risk due to rabies? So it must be notified. There must be an effective system of disease surveillance. Rabies control and vaccination must be fully implemented, including the mass dog vaccination, the identification of effective procedures for importation of dogs, cats, and other mammals, and management of stray dog population. Again, the service of the said trained individual shall be limited only to rabies vaccination injection in dogs and only during government mass vaccination campaign in accordance to RA 9482. Like this one. These are the schematic for categorizing level of rabies risk in subnational components. If it's high risk, medium risk, and low risk areas. How do we describe the level of certainty? The following description must be answered. Animal rabies situation, status of the vaccination coverage, and human rabies situation of the region or in the area, city or municipality. And they must be prioritized according to level 1, 2, 3, 4. So this is a proper way of holding your dog for vaccination, and temporary muzzle if the dog is aggressive. Next, as I've said earlier, proper way is an effective system with disease surveillance and response. So under the PIDSAR, we have the case definition of suspect, probable, and confirmed. The following table shows the following manifestations and how we categorize it according to case definition. This is the referral system from the barangay level to the RHU, to the city or provincial, CESU, regional, and the National Epidemiology Center. So again, the role of the Animal Bite and Treatment Center, as well as the health providers, ABTCs are sources of free rabies vaccine for human victims. Watch for warning signs. Check on the other parts of the manual. Warning signs to watch for the suspected dog, and continue and complete the prescribed vaccination doses. So this is for the year 2023 to 2025. These are target audience and communication objective. These are the following key messages and the locus of responsibility. So how do we maintain and renew our ABTC accreditation and ABTC personnel certificate of operation? There must be a physical setup. There must be enough manpower, sustainable supplies, systems, and the capability of the management. So this is how we report. So the outcomes who received either the PrEP or PEP must be classified C, I, N, C, D, or N. So this is the flow and the schedule of reporting from the different units. So the partial report shall be given every 15th day of the succeeding month of the following quarter. NARIS, or the National Rabies Information System, it's a computerized and, of course, through internet. It facilitates data collection, aggregation, utilization, and capacity to perform drug inventory. All the stakeholders have the access: DOH, DA, WHO, LGU, RHUs, HOs, ABTCs, and NGOs. Okay, rabies, educate to eliminate. Do not forget, March is Rabies Awareness Month, EO 84, and World Rabies Day is September 28th. Thank you for listening. I hope you get something out of the lecture video. So before I end my video, please answer the post-test questionnaire. It's only a 10 items questionnaire. Thank you and good day.